Hi, everyone. I'm Eileen Reed. I am the past Director of Education of the Canadian League Against Epilepsy, and it is my great pleasure today to introduce you to Dr. Esther Bui, who is my colleague and a epileptologist and clinician educator at the University Health Network and the University of Toronto. Dr. Bui's clinical and research interests lie in medical education and advancing the care of epilepsy. And in particular, she has a special interest in the management of women with epilepsy and epilepsy in pregnancy. She has helped to develop Canada's first accredited women's neurology fellowship training program at the University of Toronto, which she is co-director. And she's also director of the Epilepsy Fellowship program here. So Dr. Bui is going to talk to us today about epilepsy in women, pregnancy, lactation, and menopause. And I just ask that if you have any questions, to please share them in the chat, and we will get to those after the presentation. And Esther, you still can't share your screen?
I think I will be able to right now. Can you see it?
Perfect. Really looking forward to your talk. Thanks.
Great. Thanks, Eileen, and JP and Rajesh and all the really hardworking team members behind the Canadian Epilepsy Teaching Network. It's a real pride and joy as the CLAE initiative for education. So I'm grateful to be invited and really looking forward to sharing with you some exciting myth-busting information. So my interest is in women's issues in epilepsy, and have a special interest in advancing our understanding and our care for women with epilepsy. To go to the, I have really no relevant financial disclosures to this talk. And the objectives really over the next 45 minutes is to highlight our current understanding of how sex hormones can influence epilepsy, and not just epilepsy, but it's also its treatment and our decisions for drug choices. And using the Catamine model as a beautiful real world model of how hormonal influences can impact a woman's health. And then providing you with some recent myth-busting evidence-based data that gives us a better understanding of fertility issues for women with epilepsy, as well as our best practices in caring for women with reproductive potential. And finally, I'll highlight some breastfeeding recommendations. And as you can see, my palette is full, and so we won't be highlighting menopause today. I'll also share with you some really exciting work that we've been doing in collaboration with the North American Pregnancy Registry and looking at specific Canadian data to further enhance our understanding of our own population that we care for. I couldn't do a talk like this without understanding where we are at ground zero. And this is a beautiful graph of what is currently being done in neuroscience research, and with a special lens on sex bias and equally important, sex omission. And these are pie charts of current neurosciences research as of 2017. In 2015, the NIH stated specifically that sex really has to be identified as an important biological factor in all neuroscience research. And so since then, we've had really high quality data understanding what are some of the variabilities in our sex and gender research. If you look in the gray bar, really unfortunately, in the gray section, the male and female sex as a component is really not considered. And this is even more pressing in human studies than in animal studies. A very humbling reminder of how this is important is that our model of pain is based on the rat or rodent male model of pain. And it's a very different set of pain models when you look at female rats, in that there are different series of events that happen in male rats. It's more of a T-cell mediated model, whereas in female rats, in female rats, it's more of a T-cell mediated model and more of a pro-inflammatory model compared to the male rats. And so our understanding of neurosciences as we know it is based heavily on either no information on sex influences or a heavily dominated male influence on animal models and human models. So I'm hoping to shout out to all those researchers, especially our next generation, that the landscape will quickly change and we'll be able to understand better the dichotomy that sex and gender can influence. Epilepsy is no exception, and if you look here at many factors that can influence females and women throughout the course of epilepsy, the menstrual cycle and adolescence care, as well as the genetic determinants, including X and Y chromosomal influences on presentations of seizures and epilepsy. But pregnancy and postpartum have taken a big bulk of our research focus. What's less focused on is menopause, and I think the tide is changing. We're working at the International League Against Epilepsy level to bring a highlight onto the needs of our aging population when it comes to through the lens of sex and gender. And COVID really has blown this to a next level where really women have had one of the biggest impact of COVID's aspects, both in being care providers and part of the workforce that has had the biggest exodus out of the workforce in terms of this pandemic. So it's a humbling last 2 years, but COVID has really provided a reminder that gender influences are equally important for our patients with epilepsy. And really it's 50-50, 50% of our patients are females, and 25% of our patients are of reproductive potential. And so it is shouldn't really be a subspecialty, but really part of the integral aspect of caring for all patients with epilepsy. In the world of women with epilepsy, where does our evidence originate? It is dominated by prospective observational studies, really led by the key pregnancy registries across the world. But there's been some exciting information coming out from the MONEEDS studies, as well as PRAMS, WEPOD, and the Epilepsy Birth Control Registry, all really informing us on how best we can advise our patients in some of those really important questions in the trenches in the clinic. And guidelines have been few and far between. I was hoping that there would be a recent guideline announced this year, but I know it's imminent. And so the American Academy will be hopefully publishing a long overdue update on guidelines. Really, if you wanted a nice summary, the International League Against Epilepsy has recently published an expert opinion piece that provides a very beautiful roadmap for those caring for women with epilepsy, specifically in pregnancy. And just to remind us how far we still need to go, you know, the guidelines for women with epilepsy, despite women being 50% of the epilepsy population, is an overwhelmingly small minority of the guidelines being published across epilepsy. So I'll dive right in and remind you from your third year medical school days of the hypothalamic gonadal pituitary axis. And there's no escaping this when it comes to women's health, in a sense that every month this axis is fluctuating and constantly changing. And it's really the interplay between estrogen and progesterone. There are important feedback loops as well that can influence this. A very nice demonstration of this axis is the rise in prolactin following a generalized seizure or a syncopal event. Anything that has a Control-Alt-Delete on the brain results in this influx and rise that is significant of prolactin that's detectable within 20 minutes. So this is a nice demonstration of this axis in vivo. If simply put, estrogen is a proconvulsant. It's, I suspect, much more complicated than that, but the animal models, as well as some early human models, have identified that with estrogen infusion, there can be an increase in epileptogenic excitability, both at the cellular level and the in vivo level. Progesterone and specifically allopregnenolone, and please remember that I'm distinguishing progesterone and allopregnenolone because it's really allopregnenolone, the natural progesterone piece that is anticonvulsant. And this is important because some of our synthetic progesterones do not get metabolized to allopregnenolone. So to prescribe someone progesterone synthetically is not going to achieve what we're seeing in some of the animal models and human models. But allopregnenolone is anticonvulsant, and it really acts on the GABA A receptors, both at the extrasynaptic and synaptic area. This is a beautiful cartoon that summarizes many animal studies, and effectively in the 3 hexagonal and pentagon cartoon, that is allopregnenolone. And allopregnenolone modulates both the orange intrasynaptic GABA receptors as well as the blue extrasynaptic GABA receptors, resulting in both phasic and tonic prolongation of inhibition. And so a beautiful cartoon that reminds me that there is an evidence-based understanding of some of the neurochemical effects of allopregnenolone. I'll jump into catamenial epilepsy because this is real-world interplay between estrogen and progesterone. And simply put, this is I don't think you can go to any women's with epilepsy talk without seeing this beautiful diagram that maps out the hormonal interplay in the 28-day cycle that most women experience. And if you can see here, the blue line is estrogen and the red line is progesterone. And there are 2 window periods, both in ovulation, which is called the C2 pattern, and in menstruation, that the ratio between estrogen and allopregnenolone is at its highest. And those are the 2 peak periods and 2 key patterns of catamenial epilepsy. And catamenial epilepsy is defined by a doubling of your seizures during specified times of your menstrual cycle, or a near exclusive occurrence of your seizures. Now keep in mind that not all women have catamenial epilepsy per se, but 70% of women do endorse an exacerbation of their seizures at around specific points in their menstrual cycle. And so these are important historical features when you're taking an epilepsy history. One interesting thing is that there has been probably one of the few and far between randomized controlled trials that looked at whether supplementation of progesterone can diminish the ratio that we're seeing here and mitigate the risks of seizures for women with catamenial epilepsy. And that's the famous progesterone treatment trial at the very bottom here, led by Dr. Herzog in Boston. This is a beautiful table. I refer to this table all the time. Elizabeth Gerard published this in the Continuum a few years back, and it highlights really all of our known treatments for catamenial epilepsy. I want to highlight a couple of really important things on this chart. Many of us have in the past prescribed acetazolamide as well as clobazam, and those are the doses that are described in the literature. But look at the N of 20 and N of 18. And so what we are basing our treatment therapies on for catamenial epilepsy is a relatively limited population and relatively old data. So this is for some, clobazam, for example, is over 30 years old. Progesterone, going at the very bottom, this is really natural progesterone, as emphasized with the allopregnenolone point. And one of the 2 key points that came out of this study was that unfortunately there was no clear distinction between the treatment group and the control group, but a pre-specified analysis of the C1 pattern, which is women who have worsening of their seizures during their menstrual cycle, did notice a significant reduction. And I suspect that it's easier to recognize when you're menstruating than when you're ovulating. And for those who are interested in helping women identify their menstrual cycle, the best time to recognize when a woman is ovulating is 14 days before their first day of menses. And so it's really a retrospective look and a retrospective calculation of when their ovulatory period is. And another kind of clinical pearl is that a good portion of women with epilepsy have anovulatory cycles, and those women, all bets are off. And so rather than having those two peak windows in ovulation and menstruation, you would have a two-third period of your 28-day cycle called the luteal period, where women are at higher risk. And so don't give up if women are expressing that there may be a catamine component to it. Just make sure that they're not anovulatory. I'll move on to contraception, which is a very important aspect, mainly because of our concerns for anti-seizure medications and major congenital malformations. One of the most devastating things to experience, and I've only fortunately had a handful of cases, was an unplanned pregnancy with a major congenital malformation. What do we know about contraceptive use among our patients? I think this is probably some of the most recent data that has come out. Two really important take-home points. We're simply not doing good enough. When patients ask their specialist, whether it's their gynecologist or their neurologist, about contraceptive care, in one focus group, they were directed to the other specialist. And so, there's nothing more frightening to a neurologist than a pregnant lady, and nothing more frightening to an obstetrician than a seizing patient. And so I think this is a gap that we need to cross and divide and open our level of communication and comfort. What's really important, though, is in a retrospective review that was led by Elizabeth Gerard in Chicago, was that if we actually did counsel patients on contraceptive care, we made a significant impact that women who were counseled on this, especially for IUD use, had a higher rate of IUD use than those who weren't counseled. And unfortunately, real world practices that only 1 in 3 women who are of reproductive potential were counseled on this. And another interesting part of this retrospective chart review was that if this counseling session did not occur at the very first visit, it was unlikely to occur in subsequent visits. So I integrate contraceptive counseling in all new patient encounters and have it documented at least once in their new patient visit. What are women actually taking? So a humbling point is that we're not doing enough, and we can certainly do better. Of those who are on contraceptive, doing contraceptive practices, about 70% are using highly effective contraceptive methods. Another humbling point, which is 1 in 3 women are not, and 1 in 3 women taking seizure medications are at risk for an unplanned pregnancy. The PRAM study, which is more of a population-based review, confirms this gap as well, but does provide a reassuring signal that women with epilepsy do have a higher rate of permanent or long-acting contraceptive practice than women without epilepsy. And so the message is getting through that there is a concern for unplanned pregnancies in this cohort, but perhaps we can certainly do better. And this is a very nice table that will hopefully be published in the upcoming continuum that outlines contraceptive practices for women with epilepsy and options that you have. In the gray section, you can see that these are combined contraceptive options, combined meaning there's a mix of both estrogen and progesterone, whereas in the white section, it's progestin only. One of the really important points of these combined contraceptive options is that the enzyme-inducing medications can interact and lower the estradiol level. And once that's lowered, especially at the 10 microgram base that many of these newer contraceptive combined therapies have, you may get breakthrough bleeding and you may get an unplanned pregnancy. Now, if there's also the estradiol component, it's also important to recognize that estradiol also interacts with lamotrigine and can lower lamotrigine levels significantly. The progestin-only pills are also somewhat, to a lesser extent, affected by enzyme-inducing anti-seizure medications. But really, the best choice for women with epilepsy is an IUD. Now, there's two IUDs types. There's the hormonal IUD, which is oftentimes progesterone only, also known as the Mirena, and then there's a copper IUD. The hormonal-based IUD has no systemic impact, and so what it does is it acts locally, meaning that you're less worried about enzyme inducers with hormonal-based IUDs. I'll move on to fertility as a next step, and then finally highlight the pregnancy data, which is really the bulk of much of the research going on around the world. Historically, women and people with epilepsy, not just women, have a low marriageability rate and low birth rates. It's historically very difficult to disentangle the socioeconomic impact from biological factors that can influence a woman's choice to conceive. And in fact, some women actively choose not to conceive. An interesting UK study identified that 1 in 3 women just decided, and I see this regularly in my practice, that they personally do not want to have a family or have children because of their epilepsy or their seizure medications. There are risk factors to infertility that have been identified, again, usually retrospectively case-based or population-based. And effectively, the take-home point in this is that the more disabled you are with your epilepsy, the less likely you will have children or have a pregnancy. One of the most recent and exciting mythbusters that have come out in the last couple of years has been understanding, and successfully disentangling the socioeconomic impact from the biological impact about fertility for women with epilepsy. And Paige Pennell with the WePod study looked at this and looked to see if women with epilepsy compared to women without epilepsy, control women with chronic illness, had any difference in fertility. And they looked at this in a reproductive age cohort, and really the first, one of the first ever prospective study exploring this. And if a woman does not have a pre-existing fertility issue, such as polycystic ovarian syndrome or other endocrine or gynecological cause, if a woman comes in and asks you what is her chances of conceiving, based on this study, you can provide very reassuring evidence to say that you have every chance to conceive like any other women comparatively. And so there was no difference in time to pregnancy for these women compared to their control group, no difference in pregnancy rates, live birth rates, and miscarriage rates. So very reassuring. 5 years ago, I was telling women that there was a concern for infertility, especially with focal epilepsy and temporal lobe epilepsy. This study has broken this myth, and now I'm able to say that you can conceive if you choose to, and you don't have a pre-existing history of infertility. A very interesting and reassuring study, another kind of myth buster before the myth has actually developed, has been what are the rates of assisted reproductive therapy for women with epilepsy. And Denmark is fascinating. It's a country that allows for fertility treatments for all of their population. So as long as you're under 41, you do not have to be married. Single women are allowed to have government-funded fertility treatments, not just 1 cycle, but 3 cycles. For anyone who studied this, the average success rate is only after 3 cycles as opposed to the first cycle. And so it has really one of the world's largest observational cohort on reproductive and health outcomes in this special group. And the big take-home point from the Danish study is that there's absolutely no difference in success for fertility treatments for women with epilepsy and the general population. So no difference in birth rates after embryo transfer, and even more reassuring, whether you're on seizure medications or not, this does not impact your fertility success rate. So I'm able to provide 2 really important positive counseling pieces for patients in the women's epilepsy program. One is that you have every chance to have a family if you choose to do so. And if you are unable to due to fertility issues, you have every good of a chance to become pregnant through fertility therapy as in the general population. So I'm going to jump right into pregnancy because this is really the bulk, no pun intended, of our work here. The pregnant body, I tell my patients and our students, is a superhero body. You ramp up your creatinine clearance, you ramp up your liver metabolism and oxidization, especially glucuronidation, which is important with our lamotrigine and valproic acid metabolism. And you increase not only your volume, but you redistribute your protein concentration. So highly bound protein drugs such as pregnenolone and valproic acid are influenced by the changing pregnant body. Now, in the gray box, which is equally important and unfortunately sometimes more important, there are non-physiological factors. There's misconceptions, myths, which can prompt into non-adherence. I think on a quarterly basis, I will get a woman who's a healthcare practitioner, whether through emergency or through general practice, will stop seizure medication because of concerns for major congenital malformations. And in the last year, there's been 2 or 3 convulsive breakthrough seizures in this population, and equally important drug-drug interactions that women may not be aware of. Highlights of our current guidelines. This is what you need to know if you're caring for women of childbearing potential, is effectively to avoid Valproate and Valproic polytherapy when possible. During the first trimester, it's really important as valproic acid is well recognized worldwide to be the highest risk for major congenital malformation. And ideally throughout pregnancy, if possible, with Valproate being now clearly recognized that second and third trimester exposure can impact cognitive outcomes. And this is really stemming from MONEED study, but also studies across the world, also led by studies in Europe, that can impact children's IQ as well as behavioral outcomes, such as autistic spectrum disorder. Drugs have been associated with small progestational age in children. All women should be on a folic acid supplementation. What that dose is still to be determined, but at least 0.4, and for most of our patients, 1 to 3 milligrams of folic acid. And monitoring lamotrigine, carbamazepine, pregnenolone, and many of the drugs, especially the newer drugs, including Levatoracetam, throughout the course of pregnancy. And therapeutic drug monitoring is really the newest and most important aspect of this field of work. And then you can counsel patients that the most reliable prediction of seizures during pregnancy is the preceding 9 to 12 months. I'm going to jump into our pregnancy data. There are really important aspects of the registries that we glean our information from. The first is to recognize the limitations of this data. These are observational, it's not randomized, nor is it blinded. They're prospective, and the primary goal for many of the registries is to look specifically at major congenital malformations. Genetics and minor congenital malformations are excluded. And there's variability in different pregnancy registries. And this is a little bit of a cheat sheet for those who are ever reading an outcome of any major pregnancy registry to provide you with some of the important distinctions of the 3 major registries. Europe by far is the largest. Europe is a bit of a misnomer. It's not European countries only. It includes Australia. It includes also India. The Kerala registry is part of Europe. It has published really important independent results as well. Europe results are predominantly enrolled through physicians, and so these patients tend to be a little bit more involved with their healthcare team, tend to have more severe epilepsy, whereas the North American registry is self-enrollment, and so physicians can refer patients, but patients need to call that 1-800 number or send that email, and a lot of the data comes from direct contact with the women and their observations with their children. The UK and Ireland registry is a smaller but a significant contributor to our understanding of pregnancy outcomes. So this is a summary of the 3 major registries. Feel free to borrow or take. It's taken from the beautiful paper that Dr. Thompson published in 2019, that international league paper that I mentioned. And the take-home point is that these are the top 3: lamotrigine, Levatoracetam, and oxcarbazepine. It's important to look at the confidence intervals, because those confidence intervals give us a sense of how comfortable and robust this data is. So the wider the confidence interval, the more more scattered our data is, and the lower the numbers involved. If you look down here, Valproid is 10.3%, and this is seen uniformly throughout all 3 major registries. And so it really emphasizing that if possible, Valproid should be avoided and should not be the first choice for women with epilepsy, specifically focal seizures. So the take-home point for this is that if you can, choose monotherapy if possible, but choose the lowest dose of an effective, tolerated, and appropriately chosen drug for a woman's seizure type or epilepsy syndrome. You may be getting deja vu when you read this, because this is really the definition of medically refractory epilepsy, but looking at it on the other side of the glass mirror. And it's important to document preconception drug levels. It's impossible to do therapeutic drug monitoring fully informed when you don't know what their ideal target levels are. And so I gently encourage everyone, if you care for someone who has the reproductive potential, which is probably 25% plus of your population, is to at least have one preconception drug level available. And ultimately, all of this gets thrown out the window if a woman chooses, despite being fully informed, that drug A is their best choice based on where they are at this particular stage in their life. And finally, a really important point that's been coming out of the pregnancy registry is that it's not just drug specific. So valproic acid has been a poster child for major congenital malformation and what not to do, but it's a little bit more granular than this. What's coming out is that the effects of major congenital malformation is dose dependent. At high doses, no doubt, greater than 1,450 milligrams per day, you're looking at the highest risk of major congenital malformation. But at lower doses, if you can get away with 650 milligrams per day, if you look just 2 or 3 lines below this, these odds ratio are very similar to higher dose carbamazepine, higher dose phenobarbital, and higher dose phenytoin. So there's a risk stratification with regards to whether you can get away with low dose Valproid if this is really the best, most effective, well-tolerated drug for this woman's epilepsy syndrome. Finally, neurobehavioral teratogenicity is a new terminology that's been around for the last few years, that it's not just spinal cord, cardiac, cleft palate, but the teratogenicity that comes with neurobehavioral issues. And we're recognizing now that there are lower IQ scores with babies who are exposed in utero to Valproate, with the biggest impact in the 2nd and 3rd trimester exposure in multiple domains of IQ, and even recognized in low doses of valproic acid identified with lower verbal IQ. There's increased rates of more subtle cognitive and behavioral issues, neurodyspraxia, autistic spectrum disorder, and behavioral issues that have been identified by parents. And the good news is there's no consistent big signals. And I think that's another take-home point, is that these registries are really like the canary in the canary in the mines, in that it provides us with signals, but more comprehensive and more detailed research needs to be done once those signals have been identified. But overall, those signals have been relatively reassuring for all drugs that are not valproic acid. And there's limited data on some of our newer medications. So valproic acid, really, as I said, the poster child of what not to do. And I think the FDA has made this warning, the ILEE has made this warning, and to recognize that going from divided doses to extended release, there's absolutely no data to support us as to what would be better or least concerning. But unfortunately, much like this well-loved cartoon called The Cat Came Back, valproic acid is going nowhere quickly. And that's because there's been some concerning signals that women who need valproic acid have, when switched out of valproic acid, have a higher rate of breakthrough generalized convulsive seizures. And this is the diagram from the Europe study that looked, and in those who were maintained on valproic acid, they had a higher proportion of remaining stable, whereas those who were switched or discontinued had a broader portion that had recurrent or convulsive seizures. And so it's important to at least counsel patients when you're considering switching medications. This really nice Italian study also looked retrospectively at their women's and epilepsy clinics and noticed that the majority of women, when switched off valproic acid, the main reason was for pregnancy. There were other reasons that were identified as well, but the bulk of the decision to switch or discontinue was pregnancy-based. And then they looked to see what happened once those women were switched. And what was interesting, and notably a retrospective study with small numbers, was that there was 70% of patients switched from valproic acid to Levatoracetam or lamotrigine had a worsening of their seizures. There's two big caveats with this study. As I mentioned, it's retrospective and small numbers. And a second caveat is that it's unclear whether the worsening was simply worsening myoclonus, worsening absence, or worsening convulsions. And so I think what is important is that an informed choice for women with a concern that their seizures may destabilize or return if valproic acid is discontinued. And so this discussion, in my experience, may take months, if not years, for women to finally feel that they're ready to make any decision that's best for them and their future pregnancy. Finally, one of the biggest myth busters has been the MONEEDS results that have busted a myth that I actually personally taught in my first few years, which is be careful with the pregnant women with epilepsy because 1 in 3, if not more, have worsening of their seizures. And we can understandably have a physiological and biological basis for that in that the pregnancy body changes. But the MONEED study changed our understanding of this. And if you look here at the graphs to the right, they basically looked at pregnant women with epilepsy and compared them to non-pregnant women with epilepsy throughout the same 18-month epoch. And what they found out was that whether you're pregnant or not, your seizure frequency was the same. So I can counsel patients now to say that even though you're worried about your pregnancy, your seizure frequency will be the same as someone who is not pregnant. Now, there's a big caveat to that counseling point, which is that all of these centers in this multi-center prospective observational study were academic centers that did regular therapeutic drug monitoring. And so the therapeutic drug monitoring piece is important because though there were no differences in seizure frequency in all the seizure subtypes, there was a 3-fold increase chance that women with epilepsy during pregnancy would have adjustments to their seizure medications. And so on the flip side, you can reassure them with a caveat that you need to have therapeutic drug monitoring and dose adjustments as clinically indicated. And so I'll quickly go through this, but I'm happy to share the slides afterwards. The top 3 drugs that can change during pregnancy are the newer ones, and interestingly and coincidentally, the ones that we are most commonly prescribing, and this is lamotrigine and Levatoracetam. One interesting thing that I'm noticing, and I'm glad to receive other people's comments, is that I'm noticing that I can predict gender in my patients who are on lamotrigine 9 out of 10 times. And that's because there's been some early studies and purely observational at this time, independent from my own observation, is that female fetuses have a higher lamotrigine reduction than male fetuses, and to be determined and to be further dived into. And also women have different genetic polymorphisms that can impact their lamotrigine metabolisms. So there's a lot of competing and moving pieces to drug levels throughout pregnancy. But the big take home point is that if you're especially on the newer medications, lamotrigine, Levatoracetam, these are known to decrease during pregnancy, and therapeutic drug monitoring can decrease the risk of breakthrough seizures. And some beautiful examples of clearance levels of these drugs. The one to the left is really a seminal paper that brought the world's attention to lamotrigine changing levels throughout pregnancy. And Emma Voinescu's beautiful work on some of the newer medications to the right, which is Levatoracetam, as well as oxcarbazepine and topiramate. To highlight an important point in this slide is that there are differences in metabolism changes throughout pregnancy with different drugs. So Levatoracetam tends to increase at its peak in the first trimester and early second trimester, whereas oxcarbazepine and topiramate tend to increase later on in pregnancy in the second and third trimester, and lamotrigine can increase steadily in its clearance throughout all 3 trimesters. And so that allows us to adjust accordingly, knowing those individual drug things. Finally, valproic acid levels in pregnancy have been recognized to decrease, but this beautiful paper brought up a very important point, which is total levels can decrease, but free levels may not. So if you're noticing that women during pregnancy on valproic acid have a dropping level, please do both total and free to reassure yourself that increases in valproic acid doses throughout pregnancy, even in the second and third trimester, is truly warranted. In the absence of therapeutic drug monitoring availability, many centers do not have this available. The ILE paper from 2019 provides beautiful guidelines. Feel free to look at this, but it does give you some suggestions on what you can do without access to therapeutic drug levels. And finally, breastfeeding. I think the universal consensus is that breastfeeding should be supported. There are lots of positive aspects to both moms and babies who are breastfed, and 6 months really seems to be a turning point for some of the cognitive studies in breastfeeding in women with epilepsy. Let me show you this data. So the first data comes from the MONEED study, which shows that very reassuring signal that drug levels from both mom and baby pairs are significantly lower in babies than in mom's serum. And so most of those drugs are in the lower quartile of detectability. Some of them are just simply undetectable. And so it's very reassuring from the MONEEDS trial that in this cohort of patients on these medications, there's been no signal of concern. And so you can encourage breastfeeding even on these medications. And interestingly, despite the concern of in utero drug exposure, if babies were breastfed after delivery and for at least 6 months or more, the breastfed cohort, even with drugs on board in the breast milk, had a higher chance of a better outcome. So lower odds ratio of an adverse outcome, to look at on the flip side. So even with drugs on board, there's a better outcome both from fine motor, gross motor, and social skills for breastfed children than children not breastfed. I'll spend the last few minutes to highlight some very emerging and early data that we're looking for through the North American Pregnancy Registry that's Canadian specific. For those out there who are not Canadian, and also equally important, not from Toronto, a lot of myth busters in this talk today, and I'm hoping to bust some more myths about Toronto. Toronto is not cold. It's actually a beautiful sunny day outside, above zero. Toronto is not a concrete jungle. This is a view at the very bottom of the Scarborough Bluffs, and I've taken the big dive and learned how to sail this past year thanks to COVID, and so I'll be sailing the Great Lakes, and so come and join us in Toronto for the beautiful natural landscape. And also this Mythbuster, which I could not bust, which is we love simultaneously our Tims and our Justins. And so Tim Biebs has been the hottest thing that my kids have been chatting about for the last few days. The women's program in Toronto has been growing, and no pun intended, still in its nascent stages. We've done a lot of major milestones, including the first ever in Canada residency and fellowship training program for women's neurology. So for those out there who are still in their training program, please feel free to reach out to me if you want to learn more about women's issues, not just in epilepsy, but in stroke, in sleep, in multiple sclerosis, as well as headache. And so we're now into our second year of the fellowship training program, and hopefully more to come. What I do want to highlight is our international collaborations through the Women's Epilepsy Program. And with collaboration with Dr. Holmes in Boston and the beautiful work that they're doing there, we finally, for the first time, have access to Canadian-specific data through the North American Pregnancy Registry. I've highlighted the aspects of the NARP in my earlier slides, and I just want to dive right in to show you some of the preliminary results. What Julien Hebert, a bright and up-and-coming future epileptologist and current epilepsy fellow in Columbia has done with me this past year, has looked at the expected enrollment rate from our Canadian population compared to the US population. And through statistical analysis, we've been able to see how much percentage of patients are being enrolled in the North American Pregnancy Registry and how far below are we compared to our American counterparts. And this is the data that has come out from this analysis. We're seeing here on the very top orange bars, the proportion that are Canadian, and in the blue or teal, the proportion that is American. And by far, no doubt, the American population is 10 times greater than that of the Canadian, but this is not a 1/10 of a fraction. And so we looked again and looked at the expected enrollment rate through statistical analysis, and the blue line is really where we should be. Whereas the red bar is where we currently are. And so we still, like a common thread of much of my slides, is that we've come a long ways, but we still have many more miles to go. And I'm hoping with this presentation will encourage you all to reflect that when you do have a woman who does become pregnant in your practice, to introduce her to the North American Pregnancy Registry and encourage her to review it and consider enrolling, so that not just she can benefit from the data of the NARPAR, but future generations can improve our understanding of seizure medication impact in pregnancy. And of interest, I'll do 2 last slides, and then hopefully we'll have 10 minutes for questions, if any. We're still achieving below bar and below expected, but where are areas of most needs? If you see in the dark green, there are provinces that are enrolling women at a higher than expected incidence ratio, and those areas that are enrolling women at a lower than expected ratio. So if you're in any of those provinces, please consider and reflect how we can do better for our patients with epilepsy. And finally, why does this even matter? Why can't we just lump our Canadian patients with our American patients? Well, this early data suggests that it does matter. Interestingly, the Canadian data is different from the American data. Canadian women are more likely to be prescribed carbamazepine, Levatoracetam, and lamotrigine, and American women are more likely to be prescribed lamotrigine, oxcarbazepine, and Levatoracetam. If you remember one of the earlier slides, there is a difference based on the pregnancy registry that oxcarbazepine is of slightly lower rate of major congenital malformation. And equally important, Canadian women were more likely to be prescribed valproic acid than American counterparts. And so these are early signals, and signals are the best description of the work in women with epilepsy and pregnancy, but important signals to guide us on future research. So in summary, I hope you've learned a lot, much like I have had in preparing this talk for you, that precision medicine is not just about genetics, it's not just about individual cellular models, but taking a big step back and recognizing that sex is an important determining biological factor. And sex and gender are related, but they're also distinct. And in the world of non-binary transgender medicine, this is even more important to recognize. Women with epilepsy face unique issues. There are hormonal influences that happen on a day-to-day and a monthly basis. Fertility-related concerns are important to our women with epilepsy. We need to break those myth busters that have really taken away from women's quality of life, both in contraception and fertility, and reassure women that pregnancy in the right hands is a safe and stable period of time for them. And as many of you know who have children, a beautiful time. Postpartum care is really led by reassurance, safety counseling, and breastfeeding encouragement. And there is an overwhelming amount of data from both US and Europe partners, but we need more Canadian-specific data. So please join myself and Tad Fentano and many others at the CLAE if you're interested in this, in the Task Force for Women's Issues in Epilepsy. Feel free to email me. So with that, I'll pause. I think we have a few minutes.
Thank you, Esther. That was an excellent talk. We have a few questions in the chat, and if anyone has more, please put them there. And I just want to say I'm sorry, I forgot to mention that Dr. Bui is our new Director of Education for the CLAE. And I think as everyone can see from her excellent educational endeavors and this fabulous talk that she provided today, that we're in very good hands for her leading our educational efforts at the CLAE over the next couple of years. So going to some of the questions from the chat now, we have the first question is whether it's the level of estrogen and progesterone that is important, or is it their rate of change that's more important in catamenial epilepsy?
That's a great question. I don't think we know. And interestingly, some of the studies show that estrogen can actually be also anticonvulsant. And so it may not just be binary with estradiol and Aloe pregnenolone. I think the best understanding is it's the ratio. And so it's likely ratio, but I'm sure there's much more, including targets in the brain, as well as interacting factors, protein, testosterone, and other hormonal mediators.
Okay, thank you. There's a question about what is the maximum dose of lamotrigine and Levatoracetam that you've used in pregnancy?
So there is no maximum, interestingly, and I'm going to say this with a little bit of a tongue-in-cheek. I can tell you personally that I may have some patients. I think I have a patient on 2,500 milligrams twice a day of Keppra or Levatoracetam. And I think one of the biggest things and a big drawback from the current pregnancy registries is that it's dose-based. And so our information is based on doses. But as we all know, we have super metabolizers, we have poor metabolizers, and we have the majority in between. And because the pregnancy course changes things, some women will become super metabolizers of certain drugs. And so if you see the levels bottoming out, you simply increase the dose to match.
Okay, thank you. Someone is asking how they can increase the dose of lamotrigine in the different trimesters if they don't have access to laboratory testing of the drug levels.
So please check the ILAE paper. It's a beautiful paper, 2019, led by Dr. Thompson and many others in this field. And it provides a nice set of guidelines or supporting features. So the first take-home point from that paper is that the newer drugs, Levatoracetam, lamotrigine, are well known to decrease during pregnancy. For those who have concerning seizures, so convulsive seizures, seizures that have been resulted in injury or history of status epilepticus, you tend to be a little bit more hypervigilant and proactive. But in the ILA paper, they suggested that after the first trimester, so long past where the neural tube closes at about 8 to 10 weeks. So if you can safely get people past the first trimester, then you could consider increasing the drug dose by about 25%, 25 to 30% into the second and third trimester.
Hey, thank you. There's a question, would you recommend adding preventive clobazam during delivery for women who had frequent generalized tonic-clonic seizures during their pregnancy, especially if this is the first baby and it could be a prolonged delivery?
Great question. I don't routinely provide preventative clobazam, but it is considered an option. I do sometimes provide patients with a prescription so that they can take the clobazam in the event of a crescendoing of their auras. If women are in labor and delivery and they have a convulsive seizure, having preemptive clobazam could be considered, especially with brittle or severe epilepsy. But in general, 95% plus of patients do not have seizures during labor and delivery. So it's reassuring. In fact, only 1% have seizures during labor and delivery. So it's relatively reassuring. I don't routinely do that.
Okay, thank you. Do you suggest taking medications 3 times daily instead of twice daily, for example, during pregnancy to avoid peaks?
So I'm going to preface this by saying there is absolutely no evidence, and I think the ILAE has also said a similar thing when it comes to valproic acid and changes in dosing. But personally, I've done this. So an example that I had is a patient who has been seizure-free for many years, taking 500 milligrams of lamotrigine at bedtime. To mitigate the peak doses overnight, I tried to change her to 250 twice a day, and that resulted in recurrence of her seizures. So 2 take-home points. One is that it makes biological sense that you could do this. There is no evidence to support this at this time, and the women should be informed that you could destabilize their epilepsy.
Okay. Is it okay to increase the dose of Levatoracetam a few days prior to menstruation or ovulation for catamenial epilepsy? For example, give an extra 500 BID if they are on 1,000 BID.
Great question. And I have suggested this for some patients. And it is part of, I think Mona Sasgard did a beautiful continuum piece and included that as an option for catamenial epilepsy, with a big caveat to avoid drugs that have very low therapeutic windows, like phenytoin, that can become toxic very quickly on small increments. Some women do benefit from this. I found, though, that lots of women find it very difficult to reliably predict when to increase the drugs, and so oftentimes it's a moving target. But Levatoracetam, given its relative safe margins, could be considered. Be worried a little bit more about lamotrigine because it does also fluctuate more with the hormones and interplay, and so you may actually it might not be clear. You may be overshooting when there's an estrogen withdrawal component, and so lamotrigine may be higher than expected or anticipated.
Okay, so there's a question now about what dose of folic acid is appropriate. Some studies say that high doses, 1 to 5 milligrams, can increase the risk of autism and birth defects, but 1 milligram and 5 milligram are very different doses. I feel conflicted as 5 is covered by the ministry and might not otherwise be financially accessible to some women if they have to pay for 1 milligram daily. Please discuss your favored folic acid dosing.
That's a great question. So the expert opinion, really minimal evidence, is that 5 milligrams should be reserved for high-risk patients. So patients who have a family history or personal history of major congenital malformation. The genetic contribution of this is important. That risk can be up to 50% major congenital malformation in a woman who has a personal history of major congenital malformation combined with valproic acid use. So those high-risk populations, absolutely 5 milligrams. I give 5 milligrams to patients who are on super high doses of carbamazepine, so 800 milligrams, 900 total daily, for example. But you'd be in a safe margin to give people 1 to 4 milligrams of folic acid. And that's because that there was a study. Now, this was a study based out of Europe, I believe, that looked at the general population. So this did not include women with epilepsy or seizure medication use cohort, and noticed that women who had 5 milligrams, not 1 to 5, but 5 milligrams of folic acid had a higher association of offspring with autistic spectrum disorder. Now, it's a difficult study to fully interpret because it doesn't apply to our epilepsy population. As well, it does not remove the bias of why these women were prescribed or taking 5 milligrams of folic acid in the first place. So I think it's to be determined. If you wanted to err on the side of safety, 1 to 4 milligrams is safe, and save 5 milligrams for your high-risk cohort.
Thank you. So we have 1 minute left. I'll just quickly say that there's been some interest in menopause and epilepsy. So the committee can look at whether including that in a future talk. And then maybe we'll just quickly end with, when do you start to decrease lamotrigine and Levatoracetam after delivery?
Full of great questions today. So lamotrigine in particular is special. It tends to skyrocket within 1 to 2 weeks postpartum. So unlike all the other drugs, I tend to anticipate a decrease starting from postpartum day 3. And you decrease over a course of 2 to 3 weeks, depending on how far you've gone up, down to about 125% of the prepartum dose, just to supplement for the anticipated stress and sleep deprivation of caring for a newborn. That's what I normally do. For Levatoracetam, depending on how high I've gone up for the patients, if I've gone up higher than 125%, I do plan a decrease, but probably 1 month, starting 1 month postpartum. There is very little evidence for what I've just said, and I think it's really just standard of care or expert opinion.
All right, so it's 1 o'clock. I think we'll stop there. Thank you again, Dr. Bui, for excellent talk and for, I guess, rounding out this first year of C10 seminars. And I encourage everyone to join us again for the next session in January. We have a lot of exciting talks planned. And a final reminder to fill out the link that's been posted a few times in the chat to provide your feedback and to get your CME credits. And I wish everyone a wonderful holiday season and all the best in the new year. Thanks, guys.
Take care, everyone. Thank you.
Thank you.